Hello, and welcome back to Partnership Live, our monthly discussion with New Jersey leaders who are changing the paradigm in maternal health. I'm Marie Carl Vilsius Tulsi, and today I am so happy to be joined here today by Dr. Sabrina Chen. Hey, Dr. Chen, so good to see you. How are you?
I'm really good. Really
I
happy to
feel
be
like I haven't seen you in such a long time, then all of a sudden I see you every day, everywhere.
here. That's
But I love it. I love it. I love it. So today we have Dr. Chen, as I said before, she is nationally renowned specialist in reproductive endocrinology. Before we start getting into the good stuff, Dr. Chen, if you weren't doing this, what would you be doing?
that's a tough one because I love what I'm doing, but I'd probably be doing maybe a lot more traveling and yoga. So
Oh,
yeah,
that sounds really good. I would join you in doing that.
you
But
would.
let's get into the good
Let's
stuff. Oh,
do
yes,
it. Yes,
absolutely.
we'll talk.
After this. Yes,
Okay.
absolutely. So, did you start as an OBGYN and then you went into reproductive endocrinology? How did you get into this field? Can you tell us
Yeah,
a little
so
bit?
I got into medicine reluctantly, but I think it was meant to be because both my parents are doctors. I'm first generation Asian American. So, that's the Chinese parents' dream that their kid, goes to medical school. And they really pushed for that, and I really pushed against it. But ultimately, I was really um, it was really compelling. Biology was really compelling. Genetics was really compelling. Those were the things I really loved in college. So I did go to medical school, and I loved everything. And for a while, I wanted to be a pediatric cardiothoracic surgeon. I came up with all these ideas, but then on my OBGYN rotation. There was a huge emergency. The whole team left. I stayed behind on labor and delivery, and a young mother came in and just dumped her baby in my arms,
Oh,
basically. So that
wow.
was my first delivery, and it was
Oh.
amazing, and I was hooked.
Mhm.
So I came to that's how I came to OBGYN because it was just the miracle of birth. It was just
Mhm.
incredible. I just thought I want to be a part of this and I want to help. And then when I was going through OBGYN residency, that's right at the beginning of IVF. Like that, I'm very old and IVF is not that old.
You're not
And,
old. You're not old.
and
Experience.
experience, there you go. And IVF was just starting to be used to help
Mhm.
people get pregnant. It was still very, very new.
Mhm.
And I was at Johns Hopkins and they just started an IVF lab. So I was there kind of at the very beginning, and I just thought, this is incredible that you can put an egg and a sperm together in a little, test tube or a petri dish, and then put that embryo in a uterus, and then out comes a baby, 8.5 months later, or it was crazy. So I just said, this is what I want to do. Although I loved everything, but this has been a great field for me because it's changed so much. The innovations in this field have been enormous in the last few
Mhm.
decades. And it used to be very much like people were like, oh, I am not, there's no way I'm doing IVF. That's really experimental. That's crazy. I'm not doing
Right.
it. And now everybody knows somebody who has an IVF baby.
Right. And here at the partnership, we often focus on pregnancy, but so many parents struggle with the issue of fertility. And it was quite evident on Wednesday when we went to the YWCA event when we had a young lady stand up and talk about her journey
Yeah.
with infertility. And she said that she did go see you, and then it was COVID, and it wasn't quite successful at that particular time, but she ended up going through IVF and having a baby, and she was so grateful to you. How common is infertility? How common is that
Oh my
struggle?
goodness. I think, the statistics that we've seen lately, we see different statistics depending upon how you measure it. And I do think we're not quite measuring everybody.
Mhm.
There are stats from the CDC, 1 in 6 stats from the WHO, 1 in 5. So I usually say 1 in 5, 1 in 6, but
Mhm.
those are actually very cisgender heteronormative stats. So because we don't count people who are not cisgender heteronormative, there's not a lot of great data. So, and I know from my experience in New Jersey, because New Jersey does support LGBTQ family building. In fact, we support it by law. We have in our new law, we say we cannot discriminate against people for their sexual orientation, their partner status, or their gender identity, that these technologies and these medical treatments are healthcare, and
Available to
everybody
all.
deserves
Mhm.
access to healthcare, regardless of partner status, sexual orientation, or sexual identity. So I'm really proud of that law in New Jersey. I helped, with that.
Without a doubt.
And by that definition, we don't actually know what the
Mhm.
full extent of infertility is, because
Mhm.
that definition includes not just physical infertility, but also social
Mhm.
infertility.
Mhm.
Um, so I do think everybody knows somebody who is struggling to conceive. And also there's societal issues now, like everybody is feeling insecure
Right.
economically,
Mhm.
uncertainty about the future. And we
Mhm.
are seeing younger generations delaying childbearing more and more and more, and more
Yes.
people saying maybe they don't want to have children at all.
Mhm.
And
Mhm.
the United States is now experiencing this dramatic decline in birth rates that other countries have experienced, like Japan.
Yes, like France. Mhm. Mhm.
Yep. And we haven't yet done anything about that. So, and that's going to be a huge issue with, this inverse population, rapidly aging, huge baby boomer population that's getting older and older,
Mhm.
and this, smaller and smaller younger generation who's going to do all the jobs, who's going to, take care of this older generation, who's going to fund things like Social Security, all of those kinds of things. So it's an economic issue as well as, a threat to the viability of the human race. So lots of things we're thinking about lately when we talk about
There's
infertility.
so many things that we're thinking about. Um, I have so many questions for you. I don't even know
I
if we have
know.
enough time. So when we're talking about infertility, and I know you said that there are many social and structural issues, and then there are disparities. And I know when we're talking about disparities, when we talk about maternal morbidity and mortality, we talk about the disparity for Black women, 7 times more likely to die from 84% preventable birth complications. Are those same disparities within the
I
IVF?
don't think we have those disparities measured as well when it comes to infertility. There's definitely evidence for
Mhm.
disparities. Black women come to infertility much later,
Later,
and their
right?
complication rates are higher and their
Mhm.
success rates
Mhm.
are lower. We see the same thing for Latinx and Asian people as well. We don't fully
Mhm.
understand it, and there's a lot less data. And we have to think that I mean, you and I have been in healthcare for a long time. There is systemic racism
Of course.
baked into the system. There's tremendous
Mhm.
misogyny baked into the system. And a lot of infertility, even though 50% is due to male factor, it's the woman who has to undergo most of the procedures and the testing. And it's usually the woman in a heterosexual partnership that will do a lot of the navigation for a couple that's going through infertility. So
Can you say that again? I was going to get to that it is the male factor, because everybody's like, oh my God, this is something new that they're just, that's coming to
yeah,
the
no,
forefront.
it's been
The
going on for a
male
long time, but
factor.
there's so much
Mhm.
shame and stigma that surrounds infertility. And I think that shame and stigma is even greater for males.
Mhm.
You know,
Mhm. Mhm.
it's males don't like to talk, they don't like to go to the doctor. They
Right.
don't like to talk to the doctor. Usually they're at the doctor's office at the behest of a partner or a family member, or when, they're really sick, they're not usually in there proactively. And male infertility is a topic that it's just as common as female infertility, but it's not talked about very much. And there are very few physicians that are specifically trained in
Mhm.
male factor infertility. We get training as OBGYNs, but we're primarily OBGYNs. So the
Mhm.
fact that we take care of men is kind of, it's not our
Uh,
main focus.
It's
And
not in your wheelhouse. Mhm.
yeah, we're not
Mhm.
trained. We can't, we
Mhm.
don't, we don't physically examine males. And
Mhm.
so the specialty that is supposed to help men with infertility is urology. And that focus for that field is primarily on cancer and other things like that. There are only 150 board certified male
Really?
fertility specialists in the entire United States. Okay. And
150.
and
Oh,
we and
Lord.
if we take that number 1 in 5, 1 in 6,
Mhm.
couples are experiencing infertility, that is like 6 to 10 million males. Okay, so it's
Wow.
150 male fertility specialists. Isn't that
Oh, my
crazy?
goodness.
And
So that
female
even further
fertility
behind the
specialists,
people.
there's so few of us. There's
Mhm.
only 2,200 of us, but 150 is crazy.
That, yeah, that is, I thought there would be definitely more than that. So that even compounds the misconceptions that you have of fertility. People are waiting longer, but when we talk about fertility and all the different types of treatments, it's mind-boggling. So can you kind of break it down in bite-sized chunks about the different fertility treatments that are available to us? And most of the time, does your insurance pay for that? It depends
So
what kind
this is a huge topic. Most insurances, most regular commercial insurances and Obamacare and things like that will cover diagnostic. Medicaid and Medicare does not cover even diagnostic barely. It can maybe cover some of it.
of.
Treatment is another story. Like if you need surgery, which most people do not need surgery, but if you need surgery, that's usually well covered by most insurances. But the vast majority of infertility treatments, which are usually medications plus IUI, intrauterine insemination,
Mhm.
or in vitro fertilization, those are the two main treatments. And there can be all kinds of other variations, like sometimes people need a gestational carrier or donor egg or donor sperm, things like that. But those are the basic treatments. There's not a ton of treatments out there, but they are super, super effective, especially in vitro fertilization has come a long way since 1978 when the first IVF baby was born. It is used now to treat so many different issues, including prevention of genetic diseases and prevention of miscarriage. So not just infertility. So
So,
it's
Dr.
not
Chen,
covered though. It's usually
okay.
not covered, even though it is safe, cost-effective, and standard of care healthcare. And I
Mhm.
don't really understand this because right now the only people that get coverage are when your employer decides that they want to offer this benefit, or if you're in a state like New Jersey and you're under the state law and your
Mhm.
state mandates coverage. But it's standard of care healthcare. It's just like
Right.
saying we
It
have
is
to
reproductive
pass,
health and reproductive justice.
right. We have to pass a law in order for an insurance company to cover your heart attack or your
Mhm.
appendix
Mhm.
surgery. We don't have to pass laws when people have appendicitis to get their appendix
Right.
out. Why do we have to pass laws for standard of care healthcare for infertility? Why? Why is
Mhm.
that? It's
Mhm.
crazy, but you're right. It's this basic probably misogyny, the misogyny in the system, the bias against reproductive health care. But for some reason, all these commercial insurance companies are getting away with saying no to coverage
Mhm.
of
Yeah.
a standard of care healthcare treatment, which does not make any sense to me.
Hopefully we will get to change that soon enough. I have a question about when would I seek your help? Is it after a year of trying and not getting pregnant? But when do I start seeking fertility treatment?
So the standard answer is usually 6 to 12 months. 12 months if you're less than 35, if you're 35 or over, after
Mhm.
6 months of trying. And trying is not trying really hard. It's really just not using protection. Um, and that's a myth. So it's really much earlier than a lot of people go to see the specialist. People always feel like, oh, I have to try really hard. I have to figure out exactly when I'm ovulating. And really,
Right.
the natural system is supposed to work without you thinking too much about it.
Mhm.
So people should come in early. Honestly, I am starting to see some people be really proactive and actually come in before they have trouble and say, I know I want to have a child like next year. Let me go in and make sure everything's healthy. And um, and I think that's a wonderful idea. Um, our system, I think, should work that way. We have a system that's very reactive rather than proactive and very disease focused rather than focused on health and wellness. But I
Mhm.
love that when people do that and they say, I know I want to have a family and I know my health is important to being able to do that. Let me go in and talk to an expert and see, how can I set myself up for success? So I love that if when people do that. But the usual is 6 months if you're 35 and older of unprotected intercourse, or a year if you're younger. And of course, if you're in a special situation, like what if you have cancer? What if you have a chronic disease?
Right.
What
Right.
if you don't have a partner?
Mhm.
What if you're same-sex couple? What if you're transgender? What if your mom has endometriosis and she really struggled? What if you don't have regular periods? All of these things are risk factors for having barriers to fertility, and you
Mhm.
shouldn't wait. Then you should talk to an expert right away.
You should talk to them right away. So that sets you up. So then what are the other really common misconceptions that they have about that we may have about fertility disease?
I think people really feel intimidated. They're like, oh, I'm going to go in. I don't really want to do IVF. That doctor's going to make me do IVF. And I
Mhm.
think we all should have, and this was a huge theme that we both saw in our meeting yesterday about self-advocacy in healthcare in general,
Right.
that any physician, whether you're talking about fertility or anything, the first step is for that physician to get to know you and to understand your concerns and your questions, and then
Mhm.
to step beside you and go through that healthcare journey with you. So if you are ever in a position where you feel like, this physician is just telling me what to do, and it's not a conversation or you know, a team, a
Mhm.
collaborative decision, then you might have to rethink your healthcare provider because maybe
Mhm.
that's not a good fit for you. And for
Right.
infertility is that way too, especially infertility because it is your choice. Like you might not want
Mhm.
to have a kid at all. You might just be like, well, I just want to know what's going on. I don't know if I want to have a kid, but let me find out. You should have the ability to sit down, get expert information, decide what testing you want to do, decide what you want to do about that testing. Do you want
Mhm.
treatment? Do you not want treatment? I always joke, I will I will help you do what you want as long as it's not illegal or dangerous. So,
Right. So getting the right doctor is paramount. You can't just get somebody who's good enough. You have to get that person that has that relationship with you that you want to be in that relationship for the long haul.
it's
Right.
human. Everybody's a little bit different. Even if a doctor has like a gazillion awards and is amazing, if they're not a good fit, then,
And
you
they're not a
owe it to
good fit.
yourself to find somebody who is a good fit, who gets you.
Right, right. And then you just said something, people are thinking and waiting and saying, maybe not now, maybe 3 years from now, but they're being proactive. So for those people who are being proactive and maybe delaying that pregnancy and delaying, those life choices, what options are out there for them?
So I think the biggest thing is finding out some of your risk factors. Like maybe you and your husband both carry a genetic mutation that doesn't affect your health, but could lead to a very high risk to your child. And that's good to know about ahead of time to understand that and then to understand your options because IVF might be able to be helpful to you in terms of reducing that risk. And then
Mhm.
working on things like what if your thyroid is out of whack? What if you're trying to quit smoking? What if you're dealing with an addiction problem? And then Then there's things like fertility preservation. Maybe you should freeze your eggs. Maybe you should freeze your sperm because, even though you want to get pregnant before you're 40, maybe your life circumstances don't allow for that. And freezing eggs and sperm is not a guarantee of pregnancy, but it can put you in a much better position to have a better chance of success and a healthy pregnancy because age is probably the number one factor we're seeing today that causes infertility, at least
Dr.
in the
Chen,
United States.
so when I start thinking about it, I meet so many people that are like, oh, I don't have a partner yet. Maybe I should freeze my eggs. How old should you be that you start thinking about this? Like really proactively start thinking, saving, looking into preservation sites. What is the optimal age for freezing your
So
eggs?
optimal age, I think, depends upon a lot of different factors.
Mhm.
We feel like in your 20s it would be awesome to have frozen eggs.
Mm.
But that's often like a really young age, and a lot of people in their 20s ultimately will be partnered in their 30s and have no problems having kids.
Mhm.
So I actually feel from not to, like combining kind of social and medical things that between the ages, for women at least, between the ages of 30 and 35, that's a great time to think about freezing your eggs because we know that usually people have good numbers. They have we can get healthy eggs at that point, but they're also a little more socially mature, thinking about, yeah, I really definitely want to have a family, but I'm not partnered yet, so I need to think about this now. And also usually financially in a better position to freeze eggs because freezing eggs can be really, really expensive. That's even less covered than infertility. For
Right.
for males, you could maybe wait till you're older. We don't start to see birth defects due to
Mm.
age, due to male age until the males turn around 40. Um,
Oh.
I have two boys. I told them, if I don't have grandkids by the time you're 35, we're freezing your sperm. So,
Whether you
uh,
like it or not.
yeah. But freezing eggs is great, but you should also, you know, try to eat veggies and try to be a healthy weight and get some exercise and quit smoking and because those are all other ways to preserve your fertility. But yes, egg freezing is amazing. The technology is incredible now, and we do a lot of it for cancer patients because cancer patients, there are a lot of special programs to
Mhm.
cover the egg freezing process for cancer patients because
Mhm.
their risk of their cancer treatment impacting fertility is so, so, so high. And so there's a lot of wonderful programs, even for people who don't have insurance, to help us cover. And of course, we have a mandate in New Jersey to help covering egg freezing for people who have what's called
Who have specific.
iatrogenic infertility, which is like people who are getting drugs or treatment that are going to affect their fertility.
So now just, I know we have very little time left, but for people who do not have iatrogenic issues and, various comorbidities, and we do know that it is very, very expensive. Is there any other options for people who may not be financially capable, but still wanting to try infertility?
So a lot of people are shopping their jobs by the benefits. There are
Mm.
a growing number of companies, especially in the tri-state area, that offer egg freezing and infertility benefits to their
Mhm.
employees because they're trying to recruit.
Right.
It makes a huge difference for
Mhm.
recruiting and retention of employees. It's a benefit that people really, really love, and a lot of companies feel like it could give them an edge, and it is cost effective for them because if they can recruit and retain good talent, they're saving like gazillions of dollars. So it's totally worth it to them to pay for things like egg freezing.
Mhm.
So that's one thing. A lot of places will have self-pay discount and payment programs and loan programs and things like that. But but I think one of the biggest things is there definitely is there are a growing number of employers that are offering this as a benefit,
That's
which is
great
really
news. That's
awesome.
great news.
Yeah.
Um, one thing that just popped up in my mind with everything that's happening now with the current legislation and the current administration, are you getting more people who are hesitant to egg freezing and infertility treatment? See if they freeze say 6 eggs or 6 embryos. And then you use 3 now, and then they decide, okay, I don't want any more children. Are there people coming to you asking specifically what happens with the embryos, and are they concerned
Yes,
about that?
we get a lot of questions about that because there's so much in the news and so
Mhm.
many crazy things happening across the country.
Mhm.
Luckily, in New
Mhm.
Jersey, we're pretty safe, at least right now, although there is, there are some federal bills that people have written to put extreme restrictions on abortion, which might also restrict IVF.
Mhm.
And even though there was a huge outcry after IVF was shut down in Alabama, there's still a lot of legislators putting forth these personhood bills where they treat embryos like people. And when you give legal status of a person to an embryo, you can't do IVF because we work with embryos. We freeze them, we
Right.
biopsy them, all those kinds of things. So we're still in a very weird state right now in the United States when it comes to reproductive health. So I get a lot of questions about that. A lot of people want to know where are my embryos stored? Are they going to stay here in New Jersey? Right now, we're keeping everything at Barnabas. So we are going to, stay it, we're committed to keeping those embryos safe. But a lot of people who are like thinking about freezing eggs versus embryos and not ready to get pregnant for a couple of years, I always tell them it's safer to freeze eggs than to
Mhm.
freeze embryos because we don't know really
What's
what's going to happen in this country with embryos in freezers.
Mhm.
And also once you put the egg and the sperm together, you can't take them apart. And we have a very high divorce rate in this country. And who knows what's going to happen? You can't predict the future. And
Mhm.
having eggs separate from sperm is much more flexible. It just gives you a lot more options. And there's
Mhm.
myths out there saying embryo freezing has a higher pregnancy rate, and that is not true. If you are at a
Okay.
good program, the pregnancy rate is the same. If somebody tells you it's better to freeze embryos, then they might not, that's really an indication that they're not so good or so experienced at freezing eggs. So,
Hmm.
that's something that you need to take into consideration. So I do get a lot of questions. People are very concerned. I do think it's important not for people to be afraid or anxious, but to stay
But to be aware.
aware of,
Mhm.
what's happening. And
Mhm.
to reach out to your legislators and let them know, this is important to me that we continue to have access to good, safe, you know, legal reproductive health
Mhm.
care. This is important to me. It's important to my family. And, so that's the way I want you to vote. I do think we need to speak up about these concerns and stepping back, having a long history of healthcare providers just trying to stay out of politics and out of the conversation, I think is one of the reasons that we're in this position and that we have all these laws that don't recognize what good, safe healthcare is. It's because
You're absolutely
doctors
correct.
and healthcare providers have opted out too much. We really need to get involved in that legislative process and say, this law doesn't make any sense. You're putting people's lives in danger. And I think we're seeing more of that now. So hopefully we're going to make a difference, but it is a tough time.
Yes, it is a tough time, but you have answered so many of our questions. I wish we had more time, but you're going to have to come back. But before we leave, I just have one question for you. Very light, easy breezy, nothing like making life like you do on a regular basis. If you were to write an embryo, if you were to write an autobiography of your life thus far, you haven't written any books lately, have you? Okay.
Just
So
lots of talking.
if you were going to write an autobiography, what would the title be and why?
This is a tough one, but I think, what I think of first is, you know, don't take this tiny little Asian woman for granted. You, at your peril.
And I know why. Absolutely. You're a tough cookie. Without a doubt. Without a doubt. Thank you so very much, Dr. Chen. And if people wanted to reach out to you, where could they find you?
So I would love for you to connect with me on Instagram and LinkedIn. On Instagram, I'm under at Dr. Serena H. Chen. And I'm under Serena H. Chen, MD in LinkedIn. And those are the two platforms that I'm usually on. So very easy to message me or reach out to me there. And I hope to keep people up to date with current healthcare issues, especially reproductive healthcare issues, and also if I need calls to action, like I need you to talk to your legislature about a particular bill, I try to put things on there. So that's really helpful.
We'll be there looking out for those calls to action. Thank you so much. You're always so amazing, and I look forward to having you back.
Thanks for
Thank-
having me.
Absolutely. And thank you for joining us for Partnership Live, and I look forward to having you back. Take care.